All right, today we are going to do a cardiac assessment, and we just need our stethoscope and a lovely assistant. All right, so we would start by explaining what we're going to be doing. Just going to be listening to your heart, asking you some questions, stuff like that. Nothing too crazy. Best way to cooperate, just answer truthfully. Let me know if there's any symptoms you can think of that I don't ask you about, stuff like that. So we'll start with hand sanitizing. All right. Any history of heart failure for you, ma'am?
Nope.
No. Atrial fibrillation?
Nope.
Any previous heart surgeries?
Nope.
What about heart attacks or strokes?
Nope.
Do you have any mechanical valves placed in your heart?
Nope.
All right. Do you suffer from sleep apnea?
No.
No? Okay. Any chest pain at all? No? Any shortness of breath?
Nope.
Any palpitations where it kind of feels like your heart skips a beat? No. Any excessive sweating?
No.
No. Any swelling or anything in your arms, your legs?
Nope.
No? Good. Any recent weight gain that you don't know why?
Nope.
No. Okay. What about just trouble breathing at all when you're walking around the house? Do you get out of breath easy?
Nope.
No, good. What about smoking? Do you smoke?
No.
No, good. Do you drink alcohol?
No.
No, good. Are you at a healthy weight?
Not really.
Well, you're not obese. You don't
No,
have.
I'm not.
Okay, fantastic. About your diet, do you eat a healthy diet?
Not really.
No, not really. That's not good. We're gonna have to work on that one. Do you take any medications to control your blood pressure?
Nope.
Or your heart rate? No?
Nope.
Nothing like that? No blood thinners?
Nope.
No aspirin or anything? No? Okay, good. Any water pills?
Nope.
No? Fantastic. All right. So first then we would, as we're asking these questions, we would be also observing the patient for any abnormalities, possibly cyanosis, anything like that. So we're going to inspect the pericardium or the chest area for anything like that. So we would identify where the PMI or point of maximum impulse is, which would be at the apex, which would be at the fifth intercostal space to the right of the sternum. And then anything that would be abnormal, any pulsations, any thrills, anything like that where you would feel any vibrating, anything like that. So then we would also palpate for any abnormalities. We would be feeling for any lifts, like small raising of the chest, or any heaves, which would be like a large raising of the chest, because that could indicate an enlarged heart, and we don't want that. And then if we are finding any thrills, or a thrill would be like a vibration or a buzzing, and if you feel that, then you'd listen, do some listening. You'd also listen for a bruit, a bruit is a rushing of fluid, like turbulent blood flow. The best way to listen for a bruit is to have the patient hold their breath and use the bell of the stethoscope to listen for that bruit at the carotid artery. Then we are going to auscultate using the diaphragm, all of the different areas. So we are going to find, normally we would like to do this on a bare chest, but in this case we're not going to. And then we would auscultate for the apex. Again, like I said, the fifth intercostal space to the right of the sternum. Oh no, she's dead. Okay, can you breathe normally, please, ma'am? Like, you don't need to, like, accentuate your breathing. Why, as I heard your heart just fine before, now but yeah, we listened for the aortic valve, and then we would go from the aortic valve over to the pulmonic valve, which would be right across there, or across the sternum at the second intercostal space, and then going down from there, Erb's point at that third intercostal space, and then the tricuspid valve, which would be at the fourth intercostal space, and the mitral valve at that fifth intercostal space. We are going to be listening for your S1 or your LUB, which is the closure of the tricuspid and mitral valves. And then and you listen for that. And then the S2 is your dub, and you're going to hear that best at the base of the heart. And that's the closure of your pulmonic and aortic valves. We'd also be listening for any abnormal heart sounds like S3 and S4. S4 can usually be heard, excuse me, or S3 usually is the best heard using the bell at the apex. It can be benign. It can also indicate heart failure or a fluid volume overload. And then S4, you hear that kind of right before S1, and that could also using the bell. And the best way to listen to that is have the patient on their left side and listen at the apex, and that could indicate heart disease, uncontrolled blood pressure, possibly AFib. It's a late diastolic sound. It could also indicate aortic stenosis or ischemia. Those are those. And then we would, check for a pulse deficit. And for that, then we would auscultate an apical pulse, as well as checking that radial pulse, making sure that they are about the same. If they're different, that could indicate an arrhythmia, typically nature of AFib. We'd also be listening for murmurs. Murmurs are basically like turbulence and loudness that kind of goes through. Murmurs can be normal. You can have those at birth. Not usually something to worry about. They're rated on a scale of 1 to 6, 1 being a softer sound and 6 being, the louder, on the louder side. We would also be listening for any stenosis, which would be like a narrowing or hardening of the vessels. Regurgitation is more like backflow. So it's when the blood kind of backflows through through those valves. Then we also listened for like a pericardial friction rub, which kind of sounds like balloons, like rubbing against a balloon. And that is best heard at the apex of the heart, or the bottom, and having the patient lean forward. When we would listen to that way, the best way is leaning forward, and it would be, like I said, which is the pleural lining rubbing together, which almost sounds like a balloon, and indicates pericarditis or inflammation of the pleural lining. We also need to assess the patient's skin, like I said before, as we're just kind of talking and looking over the patient's skin, checking for any cyanosis, any swelling or edema of the legs, arms, anything like that, and checking the temperature as well of the skin, making sure it's not cold or hot. We want to make sure that the patient isn't having any fluid volume overload or checking kind of for cardiac disease there. We also especially check the legs, not only for edema, but for any arterial or venous problems. If it's like a venous problem, we're going to see some edema. There's going to be pain usually with standing, and the relief of the pain usually happens when you elevate your legs. Usually a need for TED hose, a heaviness of the legs. Also, you might find some varicose veins, some superficial ulcers, as well as maybe some brownish discoloration of the skin. And that usually occurs from the blood vessels kind of pushing their way out from where they belong. You also want to look for any atrial problems, which if the legs would appear maybe shiny and smooth with hair loss, you possibly deep ulcers that are very hard to heal. You're going to want to check the toenails, because if they have really thick toenails, that could also indicate an arterial problem, as well as if the patient is having more pain when they're walking, and then it stops when they sit down, which would be intermittent claudication, and that's also not a good thing to have. And then we would also want to check the patient's orthostatic blood pressures. So we would check an apical pulse, and then we would have the patient lay down for 5 minutes. We would do that before we do check the pulse, but have the patient lay down for 5 minutes just to kind of relax and have everything be even keel. And then we would check the blood pressure and apical pulse. And then we would have the patient stand up and have them stand for a minute. And then after they stand for that minute, then we check the BP and the apical pulse. And then after that, we keep them standing for another 2 minutes and then check it again. If they're a positive orthostatic blood pressure would be a drop of 20 systolically or 10 diastolically, and an increased heart rate by at least 20 beats. So that would be cause for problem as well. I hope that I have touched on everything that I need to touch on for the cardiac assessment, and I thank my wonderful assistant for letting me listen to her heart and answering my questions.